Good morning. Welcome to our Friday session of Psyfeld. Today's discussion will focus on the episode The Caddy. So for the RWJ medical students, any particular place with regard to this episode you'd like to start?
I thought one of the most interesting things to me was George Costanza's part in this whole episode. How he has this double role. He's almost like he's dissociating from his job, and he thinks it's normal.
When you say dissociating from his job, what is it that you saw?
So he has this job that he thinks he's going to get the role of the assistant to the general manager. But then at the same time, he left his car in the parking lot, and it's everyone has this misconception that he's working late. And then he goes off to the cabin in the woods where he is also living his double life.
So let's talk about double life. All right. So if we are focusing on this particular behavior and we deem that it impairs his functioning in some way, then certainly it should come under the observation of a psychiatrist, at least for academic purposes. If George Costanza were sitting in front of you in an office setting right now, what are some of the questions you may want to ask him when his chief complaint includes something about a double life, whatever that might be?
Malingering would be on my differential. So to ask him questions about what he's doing, I mean, why he's doing it, what's he doing it for? Also try to understand why, I mean, what gain he's getting from it. I mean, it's kind of hard to assess a straight up question saying, what are you doing this for? But he would probably say, knowing George Costanza, it'll probably be upfront. It's like, yeah, I'm getting this job and like, it's great. And I don't ever do any work for it.
Yep. So I don't disagree with you. I think malingering would be in our differential diagnosis. In this case, malingering was a diagnostic term as recent as a DSM-4 that focused on an individual misrepresenting themselves in some clinical way, that is either physical and or behavioral / psychiatric signs and symptoms. Okay. Individuals who misrepresent in some way may be malingering. There's more to the differential than that, but we'll get into that in just a little bit. One of the things that I think the clinician must understand is that malingering cannot be high in your differential diagnosis until other things are examined, evaluated for, and ruled out. So what other things must the clinician consider at this point in their examination?
I would put also grandiosity. So maybe he feels that he's entitled to the role. So he's probably has some elements of mania or even on his list.
That's right. So one of the things you'd have to consider is that your observation, whatever we're going to call it, misrepresentation of symptoms, is actually part of a larger condition. And perhaps that larger condition is another mental disorder. That is, if we think due to grandiosity, mania, and therefore bipolar 1 disorder should be under differential diagnosis, the question then becomes whether or not George Costanza's mania would explain why he misrepresented his symptoms. And if we can make a connection, then our treatment planning is going to be far different than if, for instance, we believe this was due to the condition referred to as malingering, right? Which again, we're going to get to in a second to clarify, right? Bottom line here is that if we truly do believe this is part of a manic episode, you treat the manic episode And we would continue to observe George's behavior. And if the misrepresentation abated, if it improved with the improvement of other manic signs and symptoms, then it would be confirmed that what we saw, that what we observed was in fact due to mania and therefore due to bipolar 1. Okay. Now, I'm not even saying that George manifests bipolar in this episode, but that's the way the clinician has to think, right? Evaluate for another mental disorder. What other mental disorders would be in our routine differential, irrespective of George Costanza? Just generally speaking, textbook, didactic. What other conditions must a clinician consider here?
Considering, sorry, we're in the same room. Can you just mute yours? Just mute it. Sorry.
2021
Considering
problems.
like personality disorders.
Right. Personality disorders. Yep. Certainly individuals with personality disorders, for example, the cluster B personality disorders, including, but perhaps not limited to, antisocial personality disorder. Deceitfulness is actually a diagnostic criterion for antisocial personality disorder. So yeah, that would be in a differential too. That probably would kind of operate in a middle ground, meaning that other mental disorders should be considered and take precedent. The personality disorders come next, and then malingering even after that, if we can kind of envision it as part of an outline or hierarchy. What else? I'll give you a hint for the site clerks. This is a presentation that I myself gave you about a week or so ago in terms of a further differential here. If someone were to present with signs and symptoms that are a misrepresentation, that is, there is a conflict between what they are telling you and what you are finding or discovering on physical and or neurological examination, we have to think of a somatic symptom disorder. And there's a variant of that in which the individual's physical signs are actually deficits in voluntary motor and or sensory function. So the variant of somatic symptom disorder, that is the related disorder, is called conversion disorder. In both cases, the person does present with signs and symptoms inconsistent with physical findings, to the extent that the clinician deems that there does not appear to be any physiologic cause for the individual's chief complaint or symptoms. When we are at this point where we definitively and comfortably can say that there's nothing physically that can explain what's going on, you may hear the term psychogenic. And that means at this point of our planning and evaluation, psychological variables are deemed to be central in the initiation and or perpetuation of the illness, psychogenic. And two examples of a psychogenic illness include somatic symptom disorder and its variant conversion disorder. In either case, the individual, while they are misrepresenting, that is, there's an inconsistency, make sure I get the terms correctly, they are not lying to you. There's no conscious effort to deceive. When the clinician understands and discovers that the patient, the individual, is caught in a lie, then somatic symptom disorder and conversion disorder are put much lower in the differential diagnosis. Once caught, it is not likely to be either somatic symptom or conversion disorder, where an individual presents with signs and symptoms that are inconsistent with known pathophysiology, but are not lying to you. So if somatic symptom, they truly do have abdominal pain and they truly do have diarrhea, but they have no organic pathology that could explain their physical signs and symptoms. For example, in conversion, they actually are blind. They can't see. but nothing from the retina, optic nerve to the visual association cortex can explain why it is they can't see. There is no physiologic explanation for the individual's loss of sight. That loss of sensory function is a variant called conversion disorder. But once caught in a lie, AKA George Costanza, those are much lower in our differential. And two other conditions pop up and are now higher in our differential, one of which is malingering. What is the other one?
Factitious disorder.
Perfect, factitious. In either situation, the individual is making a conscious effort to deceive you, like George. But again, clinical pearl, these should not be significant in our differential until there is evidence that they should be. That is, we must always give our patients the benefit of the doubt that they're not lying, that they're not consciously making an effort to deceive the healthcare provider. But once discovered, it is fair to include and consider both factitious disorder as well as the condition formerly known as malingering. The DSM-5, as of 2013, no longer has that clinical term published. However, it does appear on shelf exams, so it's a good idea to remember that term. What differentiates one from the other, since in both cases, they are coming to you with a conscious effort to deceive you?
Secondary gain.
Yeah, you have to get at their motivation, right? What's their motivation? If there is an external incentive that is governing their behavior, we call it malingering. If there is an internal incentive, that is, it's subconscious, often referred to as secondary gain, it's factitious disorder. All right, so that's George Costanza with regard to his misrepresenting his physical signs. Any other observation for George? You know, we're not going to get really much into this with regard to etiology as to why someone would feel the need to lie to a healthcare provider, and what truly is secondary gain, what true, albeit secondary benefit, collateral benefit might a person get. But there is an interesting thing in this particular episode that sheds some light as to where the clinician would look and investigate, and more specifically, I think the psychotherapist, and that his Wilhelm's voice sounds a lot like Frank Costanza's, that is George's father. And I wonder if that's Larry David giving us a little bit of a clue as to the origin of George's behavior in this episode. Any other observations about George, or now any other characters in our episode, The Caddy?
The friend, Sue Ellen Mishke. Since this was a pervasive, it had been going on for some time, since Ellen, it's found out that since high school, she's been like this, more like a personality trait, something about narcissistic personality disorder, maybe.
Yeah, she does come off as being self-centered and perhaps even egocentric. And that particular term focuses on an individual's incapacity to view a situation through anyone else's perspective but their own. And certainly either of those would pose risk for developing narcissism, which is a sense of grandiosity and inflated self-worth. Now,
maybe even some histrionics.
Now histrionics, certainly, and then even the histrionic personality disorder would be one of those conditions that may develop from egocentrism, or I should say persisting egocentrism. Individuals always start out egocentric. Right? A child does understand, they don't believe, they understand that the world revolves around them. At some point, they begin to develop empathy. And with that, they begin to see the world through others' eyes and perspectives. And if something were to happen during that normal development, egocentrism can persist beyond that developmental period. And if it does, it poses risk for a future mental disorder. And the cluster B personality disorders would be such an example. One example of a cluster B personality disorder is the histrionic personality disorder. So that's kind of the progression that one could see. Having said that, when we talk about the personality disorders, and we'll talk about them in more detail in a separate didactic, but for today's purposes, when we discuss the personality disorders, I'd like you to go about it in preparing for your shelf exam in 2 steps. Number one, I think the traditional way, and look at the way the American Psychiatric Association classifies them, clusters A, B, and C. As such, you'll clearly note that those that are in these different groups do tend to cluster, that is, overlap signs and symptoms. And so it does make learning these personality disorders somewhat easier. However, the second step that I'm now going to ask you to consider makes learning even that much easier, and that is a reorganization. Build 2 columns. The first one, we'll call it column 1, are a list of those personality disorders that adhere to a cardinal trait. Study those, know that cardinal trait, and when you review the actual diagnostic criteria, what will happen is that they will simply morph into examples of that cardinal trait, and it becomes so much easier to remember and, more importantly, identify that particular personality disorder as a single best answer on a shelf exam. On the other hand, column 2 will be the personality disorders that unfortunately don't adhere and to that cardinal trait, and therefore probably will require further study. That is just a little bit more review prior to your shelf. The histrionic personality disorder happens to be in that first column. Individuals with histrionic personality disorder have that cardinal trait of needing to be the center of attention. And as a result, their behavior is often looked upon, observed as over the top and dramatic. Now, when you look at the actual DSM criteria, it makes a ton of sense because each just is an example of that cardinal feature. In a group of people, do we identify Sue Ellen as always bringing attention to herself, irrespective of where the conversation goes? Does she say something or do something that will bring the spotlight back on her? Because if your answer is yes, she screens positive, and now we can actually look at the very diagnostic criteria to see if she has 5 of those listed signs. So what do we think?
Yeah, definitely. I feel like she, like this other woman, was very sort of unbothered by everything, which frustrated her more. And she was sort of almost projecting her own maybe like insecurities onto this other woman, but always like bringing up her own feelings about it, like their time in high school, like taking it very personally, even though it wasn't anything to do with her really, what this other woman was doing or wearing, which was interesting.
So, I mean, and I agree. So if now she screens positive, from a clinical standpoint, relatively meaningless. That is, we're not going to rubber stamp her medical chart and do anything, but offer help in a situation in which what we've just identified causes clinically significant distress or impairment. Right? That's the next step. That is, we think that there are traits here. Are those traits disordered? Specifically, do they meet that single criterion of being clinically significant? right? Clinically significant distress or impairment. The answer is no, there's nothing to do. Right? The answer is yes. That's when we pull out our pocket DSM, review those actual signs and symptoms. I think the cutoff is 5, and begin what would be the clinical assessment. A clinical assessment specifically for the histrionic personality disorder. The other thing I want to briefly mention about Sue Ellen's character is that, part of this is the fact that she is a multimillionaire. And people's personality traits are influenced by biopsychosocial factors. And her being the heiress of the O. Henry chocolate fortune may be a contributing factor to this. Maybe not. But certainly if she were to ask for help, we would have to think biopsychosocially. And I think it would be negligent for a clinician to ignore that she is an heiress to a fortune as contributing to what we deem to be clinically significant, or more importantly, what the patient would deem to be clinically significant. Doc, I need some help. So that's something to consider. And the reason why I wanted to bring that up is that it links directly to, that is, chocolate. One of the things that we might be discussing at 11 o'clock, which is another story about chocolate, specifically Willy Wonka and the Chocolate Factory. And as part of that, I want you as a clinical pearl, I don't think this will come up on your shelf exam, but certainly as a clinical pearl, to remember that the food that has the highest density of caffeine, and therefore the food that a clinician should be focused on, or at least not miss discussing, if someone were to present to your clinical practice with either anxiety or insomnia, is chocolate. It's not espresso. It's not coffee. The food with the highest density of caffeine is chocolate. Right? So an individual who has an anxiety disorder and an individual who has insomnia will need to be asked about their coffee intake, their tea intake, and their chocolate intake. And in the most severe of cases, may have a condition that is either referred to as caffeinism or caffeine intoxication. And for whatever reason, the board loves caffeine intoxication as the single best answer on a case vignette. So be prepared to identify it on your shelf. I think one of the reasons why the board loves caffeinism or caffeine intoxication is that it looks very similar to stimulant intoxication. So the medical student is going to have to decide between choice A, cocaine intoxication, and D, caffeine intoxication. It's likely that they're not going to give you any overt signs that points to cocaine. They're not going to give you the nasal septal perforation or erosion. They're not going to give you the recurrent nosebleeds. The single best answer will be caffeine when there are probably only 2 signs containing the DSM criteria for caffeine intoxication that do not appear in stimulant or cocaine intoxication. Those 2 signs are diuresis and facial flushing. And they will be 2 very high yield pieces of information in your clinical vignette that will allow you to correctly choose caffeine intoxication instead of stimulant intoxication on your shelf. Unfortunately, Larry David didn't have Sue Ellen recurrently go to the bathroom, diuresis, or present with significant facial flushing, so that this episode might be a perfect fictional case of caffeine intoxication. Then again, unlike Willy Wonka, I don't know if she dabs in the product that has made her a fortune. Any other observations about Sue Ellen Mischke? Any other characters you'd like to discuss this morning?
I feel like this could be a stretch, but I was watching the episode and I was thinking about, I was like, why is this episode being brought up this week? And I guess usually like the general topic kind of ties in to the episode. And this week is basically like psychosis and schizophrenia, right? So I was like, okay, how is Dr. Jovia gonna connect this? And I was thinking, and I was like, and I actually happened to watch this episode last night with my parents. So I was like kind of thinking out loud, I'm like, I think he's gonna say that the caddy could be like a delusion um of Kramer's, because if you like it, if you interpret it that way, because he made him like at the when he was at the trial, he kind of like leaned over and made him make this like really crazy decision. And like even though I'm aware in the episode that like the like other people can see him, so it's not like directly supposed to be interpreted by that, but I just thought it was interesting that like he was he was always like directly with Kramer and like kind of like saying things into his ear and like being that kind of character.
So let me strengthen your conspiracy theory. Um, Kramer demonstrates signs and symptoms consistent with yet another personality disorder that is either a schizoid personality versus schizotypal personality. And, I think whatever episode we might be discussing, we may land on one spot and say it's schizoid. And then in another episode, he may demonstrate, for example, magical thinking and make the differential more focused on the schizotypal. But in either case, both of those cluster A personality disorders, remember I said histrionic is cluster B, that's second group. The first group, cluster A personalities, include both schizotypal as well as schizoid. The third, of course, is the paranoid personality. And in either case, all actually harbor risk. They actually put the individual at risk for developing a future psychotic illness. And I think one of the things that this episode might actually focus on, now getting to your point, or at least supporting your point, is that progression may not be linear. As patients come in and out of our offices, we think textbook and we think, okay, well, it's going to start out being, for example, a schizoid personality. And over time, the individual is going to present with either a fixed belief, AKA a delusion, as well as perhaps perceptual disturbances. Maybe they're hearing voices, and now we're going to diagnose schizophrenia. And it very often does not work like that. Instead, what we usually see are these brief periods of psychotic illness at points in time where the clinician is still yet uncomfortable diagnosing schizophrenia. And the reason why is a condition referred to as stress-induced psychosis. And that is individuals with these conditions, and we can include the paranoid personality in this as well. But with either of these cluster A personality disorders, when the stress increases, we see periods, we see episodes of psychotic type behavior. And I'm wondering if that's what we're seeing in Kramer in this episode. I'm not going to call, and I don't think it's fair to diagnose Kramer with schizophrenia in this episode. But his pre-existing condition, that cluster A personality, schizoid versus schizotypal, will increase his risk of developing schizophrenia in the future. Right? There are definitely risk factors. But in the interim, we may in fact observe Kramer demonstrating that phenomenon of stress-induced psychosis. And if he's in court, that is a wonderful social determinant, a social factor that might actually support this idea that he has increased stress and therefore is demonstrating psychotic symptoms, albeit within the context of a personality disorder. Paranoid, schizoid, schizotypal, 3 cluster A personality disorders, 3 risk factors for a future psychotic illness, but also a major risk factor for stress-induced psychosis, even before the first break psychotic episode. That is more specifically before the onset of schizophrenia. Okay, so we're right at the bottom of the hour. We'll stop it here, and we will return around 12:30 and discuss our film during Night's Watch. See everybody back on Instagram Live.